Welcome back to Corium. I'm Brian Gilberti, and today we're tackling a rare but lethal periprocedural emergency that every EM doc needs to recognize and treat fast, which is local anesthetic systemic toxicity, or LAST. And to break it down, we have one of our senior residents, Dr. Elaine Jonas. Elaine, welcome on.
Thanks so much for having me.
All right. Let's start with the basics. What exactly is LAST, and why does it matter to the EM doc?
So LAST is when you have the plasma concentration of a drug, namely a local anesthetic, in which it exceeds the toxic levels leading to systemic toxicity. So you can get that via intravascular injection, excessive absorption, or any other exposure of a large amount of drug. You can get symptoms such as neurotoxicity, cardiovascular collapse, and those things are very time sensitive. So we really need to recognize it and treat it. And why this is so relevant is that we do blocks all the time. Think about how often we order lidocaine or another type of local anesthetic. We also see patients who come in from outpatient clinics, surgery centers, and we need to recognize that when someone's gotten a local anesthetic and they're having either neurologic or cardiovascular symptoms, that they could have LAST.
Okay, excellent point. A shift doesn't pass without us ordering lidocaine, so I'm glad that we're doing this. Now, before we get into the weeds, give me the clinical headline here. What should trigger the diagnosis when we see this in the emergency department?
So I think the main thing here is timing. If a patient comes in and they've received a local anesthetic and they have either neurologic or cardiovascular symptoms within a given window, and that could be seconds, minutes, or even hours, you should have LAST on your mind. And we can talk more about this, but essentially, you may experience an early neurologic phase, and then they can have a cardiovascular phase. But how many times do we sedate patients? Do we have patients who've received general anesthetics and then they don't have neurologic symptoms? So they may not be agitated. They may not be able to tell you what they're experiencing before having a very dangerous cardiac rhythm. And so when I say neuro symptoms and then cardiac symptoms, keep in mind that you may not get necessarily a prodrome.
Right. It doesn't read the textbook is what you're saying.
Exactly.
And so now let's tether this to a fake case and walk us through what's on your differential and where LAST is sitting on that diff.
So let's paint a picture. You are working a shift and you get a pre-note that a patient is coming in with cardiac arrest, right? So what are you doing? You're going through your ACLS algorithm, hopefully. And this patient comes in, you go through the checklist, and then you think about your reversible causes, your H's and T's, or however else you run through it mentally. But this patient is coming in from an outpatient surgical center, and they got a joint injection, or they got a nerve block, let's say. You want to keep in mind any causes of cardiac arrest that could be from that. So you want to consider anesthesia causes. Is it an airway issue? Did they get a high spinal injury from a block? Are they experiencing an allergic reaction, anaphylaxis, an embolism? Or is it LAST? And so LAST can occur when they've gotten exposure to this local anesthetic and now they're experiencing toxicity.
Now, I want to take it a step further when it comes to physiology to make it a bit more real for the listeners, because it's something that's so rare. I'm sure a lot of us have gone without seeing it in our careers. What does LAST look like at the bedside? And start with the neurologic phase.
So early on, you might experience things such as tinnitus, a metallic taste, circumoral numbness, or even agitation and confusion. However, as this progresses, you may witness seizures, CNS depression, coma, and even apnea. However, I just want to highlight something. While we say you may have a neurologic phase and then a cardiovascular phase, you may see a patient and they're already at their cardiovascular phase. So they may have received sedation, general anesthetic, and may not be able to tell you if they're having ringing in their ears, if they are confused from their baseline. So it's good to keep in mind that that may be the case, and those neurologic symptoms may be masked.
Now that's the neurologic phase. Let's move on to the cardiovascular phase. What are we seeing on the monitor?
Most commonly, you'll see hypotension and bradycardia, but you can have numerous manifestations. So conduction delays, VTAC, VFib, and even arrest. So PEA and asystole are actually more common with LAST. And unfortunately, these are often refractory cardiac symptoms. And for numerous reasons I won't get into, the myocardium is very vulnerable to local anesthetics. And you can get this very dangerous conduction pattern that won't resolve until the drug's redistributed.
Yikes. Okay. Now, timing is really important here, right? Tell us about the typical symptom time frame after injection and what causes delayed cases.
So with large intravascular injections, you can get symptoms in minutes. However, sometimes patients are on continuous infusions and drips, or let's say you're in a procedure and you keep going back and giving them more injections. Maybe just slow absorption over time can lead to a delayed presentation. So minutes to even hours. And so this all depends on the route of absorption, how much concentration, and then specific patient factors as well. And again, if this patient is very critically ill, you can have worsening of symptoms with acidosis, hypercapnia, and hypoxemia.
Now, let's nerd out, Elaine, and get into the agents. Tell us what different agents we should have this in mind for, like lidocaine, bupivacaine, and why is bupivacaine the one that everybody fears?
Okay, so as you asked for it, I'll be a little nerdy and talk about a few properties that I think our toxicologists would love, and that's pKa, lipophilicity, and then protein binding. So without going too crazy into that, any drug that's highly lipophilic will cross easily a membrane and be much more potent. You can also have sodium channel binding that is very strong, and anything that binds strongly is going to have a longer duration of effect. Especially if this drug has a slow dissociation, they're going to have fast on, slow off kinetics, which is great for wanting longer lasting effect. So bupivacaine, for example, has fast on, slow off kinetics, which is why you'll see it a lot in outpatient surgical centers for nerve blocks. And that's why we also like lidocaine, because it's fast on, fast off. So we'll love it because it's so quick, but it doesn't last that long. Now, unfortunately, bupivacaine is also very cardiotoxic compared to the other local anesthetics. And that's because it has this very strong sodium channel binding and slow dissociation at all heart rates. And it can cause a unique myocardial depression by altering calcium release from the sarcoplasmic reticulum. And that can decrease cardiac contractility. And then this is also important to note because you can get very severe refractory cardiotoxicity. So this cardiotoxicity can last hours until the drug actually clears and redistributes. So very important to keep in mind.
Okay, we definitely did get nerdy with that. Now, a lot of our job is pattern recognition and picking out which patients are more at risk for developing LAS. So what are some scenarios that we should keep in mind that should flag us for these patients are more at risk for developing LAS?
Risk factors really include any patient factors that increase the free plasma drug concentration or increase sensitivity to local anesthetics. So think of your patients at extremes of ages, anyone with very low muscle mass, underlying cardiac disease, hepatic dysfunction, renal insufficiency, or even pregnancy. Now, it's not necessarily that those conditions themselves predispose the patient, but what they come with. So if someone's very decompensated in their renal insufficiency, for example, and they have metabolic acidosis, that can worsen the presentation and make it a lot more difficult to treat. You also want to think about the type of procedure you do. So intravascular injection is very dangerous and it can lead to symptoms within minutes. So if you're doing a block very close to a large vessel, that's also risky. If you need to use high volumes, if you need to use multiple rounds of the local anesthetic, or you're injecting in a surface area that's large and need a lot of volume. So those are things to keep in mind.
Now, let's be concrete. And if we're doing a block in the ED, what prevention steps actually matter here?
I think a big thing is to just keep in mind your weight-based maximum doses and use the lowest effective dose possible. How many times do we order something and we want to order as much as possible just so we have it on hand? Well, that's great, but if you inject the whole thing and don't think about it, it can lead to issues. So I think just keeping it in mind, even if you don't plan on using the whole thing, think how many times do I need to go in and inject this patient for this laceration repair? And then also keep in mind the different types of blocks. We do blocks all the time, but certain ones, especially large surface areas, ones that require a lot of local anesthetic, that's something we can think about, be more mindful about. And then just incrementally injecting, aspirating as we do so, and then using our lovely ultrasound. That's becoming more and more popular, and I think it's a great tool for being able to see how much you're actually placing. And then also keeping in mind your rescue medication.
Good. Now, say we suspect LAS. Walk me through the workup and the immediate treatment sequence that we throw at these patients.
In any patient, if they're critically ill, you don't want to forget your normal basic steps, right? Your ABCs, ACLS if you're in the circumstance where this patient's in cardiac arrest. You want to get labs if you can. Check your electrolytes, finger stick, blood gas. Hopefully get an EKG because, as I mentioned, you can get some very dangerous rhythms. And then stop the offending agent and make sure that you're able to call for this rescue medication, intralipid, if you're really suspecting LAST. And then if this patient's having seizures, you can give benzos and then consider activating your ECMO team as well.
Now, let's say we're in this position where we have a patient where we're suspecting LAST and they are in cardiac arrest. Let's get a bit more granular here and talk about the modifications that we're making to ACLS. What are we avoiding? What are we doing differently here?
You want to keep in mind your ACLS algorithm, but actually they recommend a smaller dose of epinephrine than you would normally use. And then avoid things like vasopressin, calcium channel blockers, beta blockers, and then giving more local anesthetics. And if you're going to give an antiarrhythmic, you actually want to reach for amiodarone as opposed to lidocaine. Surprise, surprise. And then correct any underlying metabolic derangement. As mentioned previously, hypoxemia, acidosis, hypercapnia, those things can all make the presentation worse. And then consider ECMO as well.
And what are some of the biggest pitfalls that we see with these cases?
I think one of the biggest things is delaying in diagnosis. We see patients who are critically ill all the time, and to no fault of our own, we don't always get the right history or the history in a timely fashion. So we may not know to consider LAST. However, I think it's really important if a patient's been exposed to a local anesthetic, even if it's hours before, to consider this. Also, we may not have intralipid available. Some facilities and hospitals don't carry it, especially outpatient centers. And then we may not have the right dosing in mind as well.
Okay. If we're using intralipid, what are some complications we should have on our radar and keep in mind?
One thing is lab interference. Unfortunately, intralipid can really mess with your values once you get labs. It can make your glucose, your electrolytes all out of whack. And so if you can, try to draw your labs more immediately. It's not always the case. In a busy ED, sometimes patients have poor access, but try to get labs immediately and before you give intralipid because it may be difficult to track and treat some of those derangements. You can also get hypertriglyceridemia, pancreatitis, and then there is some mention as well of ECMO complications, so intralipid causing some difficulties with clotting of the ECMO filters, which hopefully we wouldn't have to deal with, but I think it's important to still pursue ECMO, and it's a little bit of a fallacy if that's indeed true.
Now, zooming out, what is the prognosis for these patients?
Actually, I'm happy to report the prognosis is pretty good once they get the right therapies. So, of course, addressing any underlying issues. Once they get intralipid and that cardiotoxicity is reversed, they can do pretty well. They can have a good neurologic recovery and hopefully be discharged from the ICU.
Okay, Elaine, this has been a high-yield segment. Let's talk about some take-home points that we could distill from what we just went over. Give me 3.
Okay, so I think the 3 would be recognize, treat, and give intralipid early. So recognize, timing is really critical. If you have a patient coming in and they've received any sort of local anesthetic within minutes to hours and are now having neurologic or cardiovascular symptoms, that's something you should really internalize and think about LAST for. Then treating, right? You want to give those medications, benzos for seizures, treat any underlying metabolic derangement, your ACLS, and then give lipid early. Make sure you know your dosing. Make sure you know if your hospital carries it, and then activate the teams needed. Get them on ECMO if needed, get them to the ICU, and hopefully they'll have a good recovery.
That's a wrap, Elaine. Thanks for coming in the studio and tackling this topic and giving us a playbook for this condition that is rare but can be catastrophic if we miss it.
Yeah, well, thanks for having me.